Hi, in this series we are going to learn about airway management. So first thing we are going to study is endotracheal tube. So in this session we are going to see about what is ET tube, parts of ET tube and how it is to be used. So endotracheal tube, the things what are it has written is it's a X-ray opaque line. It can be used both oral and nasal. It is Murphy's low pressure cuff and it is sterile one. These all things I am going to explain one by one. You can see it's a So this is the ET tube. This we call it as a tube. This is the pathway for air to move into the lungs. So there are different sizes and different length. So the internal diameter ranges from 2 to 12 size. Usually in women we use 7.0 to 7.5 and in men 7.5 to 8.5. This is the average what I am saying. This what I am showing is the ET tube of 7.5 centimeter. Okay. And it is a radio, ET tube is a radio opaque line added. Why it is added? I have already explained, X-ray opaque. So whenever we intubate, when we do the post intubation X-ray, this X-ray line helps to see the positioning of the tracheal tube in the lungs. Okay. So this curve we call it as Magill curve. This helps to follow the anatomy of upper airway, making easier insertion. So whenever we insert, this Magill curves align with the anatomy of the trachea and helps in insertion easily. So this is the tip of the tube. It is, as you can see, this is a cut in left facing level. This helps for easier passage through vocal cord for better visualization of tip of ET tube during insertion. This we call it as Murphy's eye. It is an opening cut in distal side, allows the gas to pass in and occluded. This area we call it as the cuff. There are two types of cuff. That is high pressure, low volume, high volume, low pressure. Okay. This seals of trachea. This prevents air from escaping. This prevents secretion of gastric content into the lungs. This tube what I am showing now, this is the pilot tube or pilot line. You can see this one. Okay. This is the pilot balloon. This is the lock which we can attach to the syringe and fill the air. So this region we call it as a pilot balloon. This helps with reservoir of air to reduce the effect of tracheal pressure. And whenever the cuff is inflated, this will bulge and it helps to prevent aspiration. And whenever it is deflated, we can extubate the patient. So the inflation will be of 10 to 20 ml of air. What will happen if we overinflate? It becomes rupture of the cuff. And if we inflate air more means tracheal mucosal ischemia if overinflamed. And how much should be the pressure of the cuff? It should be less. Now I am going to show you how to inflate the cuff. Take a 10 ml syringe. This is the connector. Connect it. See, you can see the cuff is inflamed. Now I am going to show how to deflate the cuff. So just connect the syringe, draw the air. You can see, here you can see the cuff is deflated. Last part, this we call it as a connector. This is the proximal end of the endotracheal tube. It's usually 15 mm. It is standard for all ventilated tubings. and use whenever we can connect to the ventilator also, we can connect to the ambu mag also. So now we have come to know about all the parts of the endotracheal tube. Now I am going to say about risk and complications. The most common complication and risk involved is the infection, and another is the pneumonia or ventilator associated pneumonia. We call it as a VAP. Whenever patient is on endotracheal tube and connected to ventilator for a longer time, there is a chances of getting pneumonia. Other things like whenever we are intubating the patient, there is chance of tooth dislodgement. Because of the teeth, there will be a dislodgement of the tooth and getting obstructed. Another one will be like, if we did not select the size of the tube improperly, there will be chances of bleeding, and there will be chances of perforation of oropharynx, and we may damage the vocal cord also. And if we keep ET tube for the longer duration, there is chances of tracheal mucosal ischemia.